Thank you everyone for being here. It's quite an honor to be here. Thank you, Hanita, for the invitation. And thanks all of you for being here at lunchtime. I know it is not that easy. My name is Kepa. I am a corneal and refractive surgeon from Colombia. And I wanted to bring you a kind of a practical approach to the use of the intensity lens or how I do it in the real world in my practice. These are my disclosures. I'm obviously a speaker for Hanita and for other companies. So essentially, we all know that the amplitude of accommodation, the way we can accommodate decreases significantly with age. And this is not something new. And this is a slide that I really like. So if we ask presbyopia patients and non-presbyopia patients how they feel, how they self-rate their vision, presbyopia patients tend to self-rate their vision way, way worse. And it causes some difficulty with routine tasks. So managing presbyopia is not only like an optical context, so not only like an optical thing, but it also increases or improves their quality of life. And this is even worse. I mean, if we ask them for the functional independence, how they feel in their everyday life, patients with presbyopia feel they need the help from others due to vision more than non-presbyopia patients. That's why I've always said that presbyopia management is essentially a human right because we are improving the quality of vision of patients. This is the new IOL classification. We will not go through them, but we will still refer to the intensity as a pentafocal lens, just to keep on with the classification we've been using before, although we do know that it's been changing. This is the focus curve that is proposed by the company, and this is the design. We are not going to go that much now into the design of the lens. I know it was talked about, a lot about yesterday. The important thing and something that is different on this lens is that the order 0 is the one that's in the intermediate vision, and the other orders are for far vision and near vision. This is something that can explain some little nuances of the lens that we are going to see in a minute. So the first thing that I always ask myself is whether I'm going to do a binocular or a monocular surgery. A little bit later, we're going to talk about a little bit of this difference. But we will start with bilateral surgery. This was a study that we published last year, I think. Yeah, 2024. It was last year, in which we just got a group of people with presbyopia and we implanted an intensity lens on both eyes. We're not going to go through the whole table. Essentially, they improved a lot, and their final vision without correction, it's really good. For far, it's really near to 20/20, and for intermediate vision and for near vision, it is extremely good. So we're not just going to go through that. This is our bilateral surgery, the focus curve. It is even better than the one that's proposed by the company, and that's something really interesting, because when we as surgeons see the focus curve that is given directly by the lab, I think we all surgeons tend to look at it like with a pinch of salt. We know, well, we don't know if it's totally true, but when we see it on our own patients and we see that it's actually better, it's a really good thing. And an interesting aspect of the focus curve of the intensity lens is that it's really flat. Obviously, there is a little bit of increase in far vision and near vision, but it's essentially really, really flat. And you talk to patients, sometimes with some lenses, they told us that they need to like look for distances. They need to search for the distance where they see better. With intensity, we don't see that with patients. They just raise their hand, they just raise the notebook or whatever, and they're seeing fine. And that's really, really good. And it's not just our data. Those are two other the focus curves by independent researchers. The first one is by Dr. Bianchi, if I'm not wrong, and the second one actually compared the monocular and the binocular. Obviously, with the binocular implantations, patients do see better. There's some binocular summation there. But the problem is that when we see this kind of research, we are always focusing on the perfect patient, the patient who's got like a completely normal cornea, the patient who has all the time in the world to neuroadapt, the patient who hopefully is a little bit hyperopic, and not all of them are perfect patients. And there is no perfect lens 100%. The intensity, I think, is as close as possible to the perfect lens ever designed. But there are still some things that we need to take into consideration to improve the satisfaction of the patient. One of them is the dysphotopsia. Dysphotopsia, all lenses give a little bit of dysphotopsia with intensities really, really small, but I have tended to change the, let's say, the psychological aspect of dysphotopsia for the patients. And something that I always like to say in this kind of conferences is that I don't consider for the patient, I don't tell the patient that these photopsias are like a complication or anything. I actually tell them this is going to happen. 100% you are going to feel this. And actually what I've started doing is I will tell them, well, I'm going to input these lenses in your eyes. I show them the picture and everything. There are some circles. You will see those circles, and they will tell me that the lens is working, that the lens is showing light from different sources. So, so the night before the first post-surgical appointment, I tell them at night the day before you will go out and you will look at the lights and you will look for the circles. If you see the circles, that means that the lens is working. So the next day they get so happy. Yes, doctor, I see the circles. They are working. It's beautiful. It's gorgeous. It's gorgeous. We're changing that. We're changing the psychology of the patient. And something else that we need to do there is before you perform surgery on them, ask them the same thing. Go out at night and see the lights, see if you see anything. Pretty much all patients have some little bit of dysphotopsia before surgery. And if they realize they have dysphotopsia before surgery, they will be way more comfortable with dysphotopsia after surgery. So if you find it after surgery, it's the surgeon's fault. If you find it before surgery, it's the patient's fault. So that's something that I've seen works very well with them. Some other things that I ask myself is how is their unaided far vision? Because a little nuance of the intensity lens is that the far vision takes a little bit, a couple of weeks to really settle in, to really have a really good neuroadaptation. So patients at first feel much comfortable with the far vision and the near vision and the intermediate vision. The far vision takes a couple of weeks. So if they have really good far vision to start with, that's something I take into consideration. Second, if they tolerate dysphotopsia and if they are in a hurry for far vision. And I've had some patients who really need really early far vision. They don't have the time to neuroadapt to the intensity lens. And this is a subset of patients we have found a really good option, and it is combining the intensity in the non-dominant eye and the full range in the dominant eye. We know the full range is an excellent lens. Objectively, by the defocus curve, the intensity gives a better defocus curve, but the full range neuroadapts really, really good for far vision very early. So I tend to combine these two. And this is my wife's uncle. This is one of those special patients. You don't want to see them complaining at every family gathering with the eye like this. So he's a really type A personality. He needed to drive the next day. He was really in a hurry for a far vision. So what I did was implanting a full range in the dominant eye and the intensity in the non-dominant eye. And it worked really fine. He was really driving the next day. And it gave me this, which is very interesting, this is the defocus curve of him. This is his defocus curve. And this is interesting because it allows us to compare the defocus curve in the same patient with the same brain and the same everything. It's the same person. So this is like the perfect comparison of defocus curves for intensity and for full range. Both are excellent. Obviously, the intensity is a little bit flatter, it's a little bit better, but it allows for comparison. It's the same brain. And I've used this combination for this kind of patients. Another thing is with those patients who have a really poor tolerance to dysphotopsia. For these patients, some surgeons will say, well, let's not implant a trifocal on them. What I've done and what I've found to be extremely useful is just to do a mix and match. A non-diffracted EDOF lens in the dominant eye and the intensity in the non-dominant eye. We do not have yet in Colombia available a needle from Hanita, so I've needed to resort to other companies by the same distributor. Once we have it from Hanita, obviously I will be using it. But in the meantime, just to let you know that they combine really well. And we have seen that the dysphotopsias felt in the dominant eye are the main reason of whether the patient is satisfied or non-satisfied. So combining those is really useful for them. And there are some studies that have shown that if we do a mix and match, combining a needle, and this is a trifocal, but in the case of Intensity Pentafocal, we do not sacrifice satisfaction, we do not sacrifice spectacle dependence, and the patient feels way, way more comfortable with the hazy vision and the blur vision at first. So it is an option. And last, just to finish, I've got 3 minutes and a half. It's unilateral surgery. What I've done, and this was presented in Colombia a couple of weeks ago by one of my residents, is that when we have relatively young patients, about 50 or something, that are emmetropic, that see excellent for far vision, they do not need any kind of correction for far, and they just want to improve near vision. What we've started doing is unilateral surgery, just implanting the intensity in the non-dominant eye and leaving the dominant eye virgin. And it's currently under peer review, and we've had excellent results. This is not a new concept. I didn't invented this. There are 2 other publications with different lenses that show that this is really useful for patients. And we all know that all lenses, no lens is perfect. All lenses always will decrease a little bit contrast sensitivity, but as patients remain with the dominant eye untouched, it doesn't change at all. They are extremely happy and they don't really notice this decrease in contrast vision. These are our results. Essentially, if we compare the operated eye with the non-operated eye, we see what we expect. The near vision improves a lot for the operated eye. The non-operated eye obviously is the same because it wasn't touched. And this is our defocus curve. This is interesting. Sorry I get in the middle, but I have nothing to point with. So this green line is the monocular non-operated eye. This eye is virgin. So we see that it starts with really good far vision and it decreases. It's expected for the age. The blue is the monocular intensity eye. We see that it improves a lot. And this is perfect to compare, again, with the same brains. This is a set of patients with the same brains, how the intensity improves the capability of the patients to see up close compared to a virgin eye. And the gray one is the binocular defocus curve, so with both eyes open. So what this shows is that implanting the intensity in the non-dominant eye and leaving the dominant eye virgin really improves binocular vision and doesn't impact negatively the satisfaction of the patients. And I asked for permission to put this this picture, sorry. She's Christina, she's the gorgeous lady over there. She's one of the main she's like the second in charge. I've never really know what the name of her charge there is, but she's one of the distributors in Colombia for Hanita. And like 2 months ago, we implanted an intensity on her left eye, on her non-dominant eye. That's the real retroillumination picture of her. I was doing bullying on her for a couple of years until she finally agreed to operate, and she's really happy. Preoperatively, obviously, her far vision was excellent. This is unaided vision. She was 20/20 for far, but for near, it was a disaster. And 5 days post surgery, just starting the new adaptation, the right eye, it remained the same, but the left eye and both eyes open were 20/20 and J1 for near vision. And I was just talking to her when we were coming from Colombia, and she's still thrilled with the results. So it really works. And if somebody who talks about intraocular lenses all the time and knows the opinion of all the surgeons in Colombia, at least, all the time, and she agreed with it and she's happy with it, yeah, it is good enough for your patients to be happy with. So the conclusions, the intensity, as I said, is pretty much the closest to the perfect IOL design so far. The results are excellent, but we really need to have into consideration what patients do we have before ourselves. If we have like the perfect patient, binocular implantation is absolutely gorgeous. It works really well. But if we have some demanding patients, sometimes we need to change a little bit our approach to that. And monocular implantation, at least for me, has been has given an excellent results. So that's pretty much what I have to share with you. Thank you very much.